So I wanted to thank everybody. I know you can be at all other sessions, so thank you for being here with Kim and myself. I want you to know that I'm not an expert on revenue cycle management, and so when Director Francis said, hey, why don't you do a panel with Kim Tolliver on Z codes and revenue cycle management, I thought, well, I said, you know, Michelle, I'm not really an expert. And she said, oh, well, don't worry. Michelle wrote the book on revenue cycle management. And Michelle said, Kim wrote the book on revenue cycle management. And I thought, oh, so she's really an expert. And she said, no, literally, she wrote the book. So here we're having a topic that I'm not necessarily an expert on with a nationally published author on stage. So, you know, no pressure, but I am going to do my best. What I want to do is address a couple of the puzzle pieces, and the director mentioned earlier today about the puzzle pieces. And I'd like to provide some perspective before handing it over to Kim on the perspective of the social determinants of health, telehealth, and interoperability, and how those things come together to really offer the potential to address access for folks who typically have difficulty getting access to health care, and for really providing improved outcome for those folks. And that all ties together then with value-based care. And as we know, value-based care is the direction everything is going. And as I think Kendra Seiler mentioned earlier today in her presentation, sometimes you look at things and you read the tea leaves about where things are going. No doubt those tea leaves are Bush tea leaves, but the tea leaves are definitely telling us that tracking social determinants of health, utilizing social determinants of health in the care plan is where things are going, because that's going to be part of value-based care. And right now, that's represented as Z codes. However, those are going to be codified and probably will be incorporated even more formally. They're already out there in some proposed standards. What I'd like to quickly do is take a recap of where we are at the end of the public health emergency in terms of reimbursement for telehealth. Next slide, please. I won't go into detail, but this is a summary of the waiver extensions and the things that have not been extended with regard to telehealth. So as we all know, there were waivers and relaxations, and with the omnibus bill that passed in December of last year, for the most part, all of the telehealth waivers were extended. There were exceptions around the Ryan-Haight Act, but as many of you know, the DEA has actually revisited that decision. And you can see in the title, Telehealth Billing Rules Extended to December 31st, 2024 and beyond. As part of the Southeastern Telehealth Resource Center, I am not permitted to advocate for any type of legislation or policy. However, it's hard to imagine that the genie of telehealth now out of the bottle is going to be rolled back. If anyone here is involved in advocacy, please speak to your legislators and let them know what your opinion is about continuing these reimbursement policies for telehealth. Next slide, please. One of the important concepts is telehealth parity, and that's a state-by-state policy. And essentially what that means is that for the states in blue, they have legislation on the books that mandates that any telehealth policies, any telehealth appointments that provide the same level of clinical outcome as an in-person appointment must be reimbursed. That's parity of telehealth to in-person services. That is a rising tide stateside. There's legislation in almost every state to move forward on it. And again, while I'm not in a position to do advocacy, if anyone here does do advocacy, does interact with your legislators, Chris, then please let them know what your opinion is on parity. It's a very important concept, and it really moves things forward. For example, in the state that I live in Florida, there is nothing on the books whatsoever, completely silent about telehealth and telemedicine reimbursement. And what that means essentially is that the payers decide for themselves how they want to treat it. And so you have a lot of variation. Parity is an important concept. Next slide, please. This is something that I think really starts to tell the tale. So look at CMS projections through 2030. And what you'll see is that total CMS goes up, if you look on the far right column, third row down, by a factor of 1.8 between 2019 and 2030. CMS is expecting to basically double what they spend. If you look at the amount that they intend to spend on telehealth and telemedicine, it's going up by a factor of 45, almost a factor of 50. So CMS is anticipating that almost a third of all the encounters that they reimburse by 2030 will be telehealth and telemedicine. What is that going to be? It's probably not going to be just all of us seeing our doc online more often. What it will be are very targeted approaches to using remote care where it can have the most impact, in particular on chronic care conditions. So you have a small percentage of the population with chronic conditions who represent a disproportionate percentage of the consumption of healthcare resources, and that's because those folks need it. What also tends to happen is that they get put into a care plan that is the lowest common denominator sort of care plan. So if, for example, Kim and I are both sharing we have a chronic condition, she may be just fine seeing her provider once every couple of months. I may be much more acute and I need to see my provider once a week. But typically, we'll see the provider the same amount because of the challenges of geographic access. With things like remote patient monitoring and telehealth, it enables people who need more intensive care, more coverage, to get that coverage. That then results in less bounce backs to the ER, better outcomes. So by focusing telehealth on chronic conditions, asthma, COPD, etc., we can have a disproportionate impact on the folks who need that help the most, and also a disproportionately favorable impact on healthcare expenditures. So when we look at telehealth, we're going to see it being applied to chronic conditions. And one of the most important things related to chronic conditions are social determinants of health. We've heard about that this week. It's very important for care providers to understand how that fits into the overall care plan and what can be addressed. And then finally, looking at telehealth as just a component, right? It's just a component of a triumvirate that is critical. The critical triumvirate is, yes, telehealth, but without broadband access, you can't deliver that telehealth to people. And without data, without interoperability, healthcare providers don't know how to create the best care plan. So it's a triumvirate of interoperability, broadband, and telehealth, and you see that in CMS. There is a tremendous focus through HHS and the ONC on interoperability, on telehealth, and the FCC is very focused on broadband. So those three things are going to come together. They're going to enable chronic care management. That's where you're going to see that big increase in spending from CMS, and that's going to drive value-based care, which, as we know, is a top policy priority. Next slide, please. This eye chart is US CDI version 4. Those are the standards that go along with the new FHIR-based interoperability. These standards that are proposed in version 4 include data on social determinants of health. So if there is any question that Z codes as they exist today will become part of the formalized infrastructure of care management, become part of the formalized infrastructure of the US CDI, you can remove all that doubt because they're already out there, they're in the proposed structure, they will become part of the overall approach to care. Why? Because that facilitates improvements in chronic care management, which is going to be enabled by broadband, telehealth, and interoperability. So understanding Z codes now and today is really important because that's going to bring you to an understanding of where everything is going. And with that, I'm going to turn it over to the real expert, Kim Tolliver.
Okay, so I did introduce myself earlier, Kim Tolliver. I'm the president of Medical Revenue Cycle Specialist. Great to be here with you today. Next slide, please. I am going to start off my part of today's session in giving you a journey through the revenue cycle. So when we get to the next slide, okay. So in order to kind of really eat this elephant, we're going to break it down into 4 quadrants, okay? So the first quadrant is pre-services. So this is information that we get from our patients, okay? So what we want to do is make sure that we're capturing the right information from our patients. The next quadrant is our claims prep. That's the information that we're getting from the provider. So during their documentation, during their encounter with the patient, we're relying on the provider for that information. And then the receipt of payment. So this is the information that we are getting from the insurance companies. So whether it's an electronic remittance advice or an EOB, we're getting information back from the payer on our claims, on our diagnosis, on our CPT codes. The fourth quadrant is the data that we house in our systems, okay? So basically, all of the other areas that we've gotten information from, we want to make sure that we're using that data for key performance indicators, quality payment program reporting, and internal business reporting and dashboarding. So these are the 4 quadrants of the revenue cycle. Next slide. Okay, so let's break down those 4 quadrants into their sections. So that first section, patient information, right? So it starts with scheduling and pre-registration. So this is where we have that opportunity to make sure that we are educating our workforce so that they capture the right information that we need from our patients during that pre-registration process. Then we have eligibility and verification. We do not want to put anything in our systems that's inaccurate. So we want to use our EDI information so that we can verify all of the data, demographic information, insurance information before we put that in our systems. Appointment confirmation. A lot of this is electronic, and as you kind of see, this is what we want to be able to do, but we want to also make sure that our patients show up to those visits, right? Check-in, check-out, time of service collections. So for the non-Medicaid, Medicare patients, there are going to be some commercial plans that have out-of-pocket expenses. This is the opportunity that we want to take to educate our patients on what their financial responsibilities are, make sure that they have follow-up visits, that they understand their treatment plan. Second section is, again, information that we're getting from our providers, our physicians, our nurse practitioners, our physician assistants. The documentation of visit. This is one of the most critical parts of the revenue cycle. So making sure that we get accurate documentation of that visit through the EHR by optimizing the use of, I like to use well, I'm not a physician, but I encourage physicians and other healthcare providers to use condition-based templates. So if you have a COPD patient population, you have a COPD type template. Coding. Now, most coding happens on the provider level, right? So we are relying on our physicians to be coders. And we're going to talk a little bit more about that, but it's really important that we're capturing the accurate coding information for these patient visits. The charge entry, one of the great aspects of charge entry now is that it's automated. So we have an encoding opportunity with our practice management and EMR software that we can actually get all of the charges pulled out of that progress note. And then our claims prep. So before we submit anything to an insurance company, we need to scrub that thing. And we need to make sure that all of that information is accurate one more time before it goes out the door. So doing that electronic claim submission. And the next cycle or the next section is going to be, again, that information that we're getting from our payers. So we're depositing our payments. We are posting our payments. Now, sometimes when we post payments, we're posting $0 payments, which are denials or non-payments, right? That's still information that we need to track. Denial management. The last thing that we want to do is not be the squeaky wheel. So what we want to do is make sure that we're following up with our insurance companies to find out the reasons why they have not paid for our services. But most importantly, what we want to do is understand and interpret their complex regulations and their rules for reimbursement. Insurance follow-up, I was having a discussion with someone yesterday, I think from Gainwell, and is anyone familiar with the aging AR buckets, the aging AR cycle, and what that looks like? It used to be 0 to 30 days, 31 to 60 days, 61 to 90 days, and then 120 days. So what my hope is to disrupt that aging AR, because it was based off of the US Postal Service. We don't mail claims anymore. So why are we waiting 30 days to start working our aging AR? We should definitely start working them within, that 14-day period, because those claims are being submitted electronically. Then we have our patient AR. Again, this is all about patient engagement, using patient portals, using other electronic techniques to make sure that we're able to electronically capture reimbursement, co-pays, balances from our patients securely. And then that fourth quadrant, as we break that down, are key performance indicators. What denial trends are we seeing with our insurance companies? What prior authorization needs are we missing out on? What medical necessity documentation have we not provided? That's the type of KPI data that we want to have access to. And then the quality payment programs. Many healthcare organizations are participating with either MIPS, advanced alternative payment models, and other QPPs. So what we want to do is make sure that we're capturing all the data from those, for those programs. And then what we want to do is business planning. So we want to do our own internal financial reporting. I recommend that physician practices and hospitals look at this on a weekly basis, on a monthly basis, on a quarterly basis, biannually, and annually. So making sure that you're looking at the right data. How often are you adjusting off claims for timely filing? Those are the types of reports that we want to run. Now, let's bring social determinants of health into the revenue cycle. Next slide. So when we think about data capture for social determinants of health and mapping that to the revenue cycle, what we want to think about are those areas of opportunity, the touch points within the revenue cycle that are impacted by social determinants of health. So when we have staff who are scheduling patient appointments, we want to make sure that we're getting a chief complaint. What's the reason for the visit? And let me tell you, as a coder, when that patient shows up to the appointment and they're in the room with the physician and the physician just sees follow-up, we don't have an established chief complaint. So what we want to do is arm the physician before they get in that visit with all of these social determinant of health information. We don't have enough time for me to go through every single one of these, but as you can see, SDOH impacts every single sector of the revenue cycle. One of the areas that I do want to look at, though, is Z-coding. So when we're thinking about promoting the use of Z-codes, Z-codes are something that we want to make sure that our providers understand why they should be using them. One of the great things that we're seeing with Z-codes, I think about 2 years ago, we started getting access to SDOH Z-codes. Prior to that, we had preventative medicine Z-codes that were widely used, but the SDOH Z-codes are still kind of a mystery. So let's go to the next slide so we can talk a little bit more about where Z-codes are impacting us. So this is a case study from the ASCO, and it talks about a 50-year-old patient with breast cancer getting chemo who is dealing with side effects, but she's also taking care of her elderly father. And she has a great amount of stress. That is a social determinant of health. So if you are a healthcare provider and you're doing this documentation, you have set up this medical record to start providing Z-codes based off of the SDOH information that we've gathered. So as you look, The Z code category that we have here is the source of her stress is related to the care of her father. So that's Z63.6. Now, that actually gets broken down even further. That's just the category, okay? There's additional information that we can add to that. And I won't go through all of it, but as you can see, there's kind of a decision tree that you can use to give a more specific. Any kind of diagnosis code should have its highest level of specificity. So when we think about how we're going to optimize C codes, we start that by optimizing the provider's documentation. What I have done here is given you access to additional information about Z codes from the ACSO. Next slide. Okay, so this is a list of the Z code categories. Z codes are official ICD-10 CM codes, okay? They do not have relative value units associated to them, meaning that they do not have reimbursement directly tied to them, but we're gonna talk about that indirect tie to reimbursement. So again, these are the categories, and each one of these categories has a drop-down subfolder that gives you additional specificity on that patient's illness and treatment options. What I've done here for you, if you choose to look at this, is I've given you a Z code browser from cdc.gov. So what we want to do is make sure that we are encouraging individuals to select these Z codes. Now, a couple things about Z codes that we need to kind of preface is that Z codes cannot be primary diagnosis codes. So if you have a patient with a chronic illness or another reason for their visit, we have to use that first diagnosis code, the reason for the visit, the chief complaint. And then our secondary or tertiary diagnosis code is going to be that Z code. Everyone staying with me so far? All right, next slide. All right, so I mentioned previously that Z codes themselves do not have relative value units associated to them, but they impact reimbursement, they impact care coordination, and they impact outcome. One of the ways that they are impacting is through risk. So when you have a patient who has a social determinant of health who could have a Z code appended to their visit, what we want to think about is how are we demonstrating to the CDC, to CMS, to Medicaid, the complexity of the medical decision making and the mortality and morbidity of this patient without giving them a clear picture. One of the ways that we can do that is by demonstrating risk. So I've given you a definition of risk adjustment, but basically, I think, I forgot who mentioned it earlier in the conference, in the summit, but it's a way to reimburse healthcare providers for certain patient populations. So what happens is there is a projection of healthcare expenditures. If that projection is based off of diagnosis codes. So when you think about that fact that it's based off of diagnosis codes, we're projecting in advance. Payment is being made in advance. What do you think happens if the expenditures are inaccurate or miscalculated? It impacts the revenue for the next cycle, right? So when our providers are not painting a clear picture of the complexity of the patient population that they're treating, that's how it starts impacting population cost reduction. So that's something that we want to avoid. By using Z codes, we're able to now demonstrate the complexity of the patient population that we've treated. And I've kind of given you a risk adjustment sequence here. So the payer is going to estimate healthcare costs, right? Then the provider documents the health status through their EMR, most likely. Hopefully, they're selecting an ICD-10 Z code. And then there's an assignment of a hierarchical condition category code. So I'm going to throw another new word out there for you. Anyone familiar with HCCs, hierarchical condition categories? So HCCs are groupings of diagnosis codes for chronic illnesses. Now, couple of things about HCC codes is that they have risk adjustment factors tied into them. Those risk adjustment factors help with those expenditure predictors that I talked about earlier. So some of them are going to be ESRD, COPD, asthma, depression, substance abuse. So it's really important for us to demonstrate our risk by using those HCC code sets. Once the assignment of the risk adjustment factor happens, the payment of the healthcare expenditures occurs. Again, this is population based. This isn't, per member. Next slide. So when we think about the revenue related to risk adjustment factors, again, the risk adjustment factors are happening from CMS, they're happening through ACOs, accountable care organizations, clinically integrated networks, and the goal here is to determine the complexity of a patient population and then reimburse based on that patient population. So when you look at some of the examples that I have here for you, so we have documentation of an 82-year-old male, low back pain. When a provider documents a diagnosis code of low back pain, there's no HCC risk adjustment score associated to it, okay? I missed one of the other, some reason why the table is gone. But, so this individual has this risk adjustment factor of 0.561. These risk adjustment factors have dollars associated to them. And I'm gonna translate that into dollars in a moment. Now we will look at how we've documented and coded that next patient, lower back pain, no HCC, CHF, now we have an HCC. There was another slide. Sorry, I don't know what happened here. Our formatting was off. So my calculations are off a little bit. But look at our last documentation. We have CKD stage 5, CHF. We have a higher risk adjustment because of our documentation, okay? Let's turn that into money. Next slide. All right, so when you're calculating it, you have your risk adjustment factor, right? Just being a male between 75 and 79, the age, we've gotten a risk adjustment factor. Look at the annual projected expenditure. So if we're capturing male, 82-year-old, other SDOH factors, this is our expected expenditure. Acute myocardial infarction, COPD, renal failure stage 4. Again, so you're seeing how the risk adjustment factors are being tied to revenue. What do you think would happen if we missed any of these diagnosis codes? Lower reimbursement, poorer outcomes. So this is the motivation to include Z codes. They're not HCCs, but they complement the HCCs because most patients who have any of these illnesses have additional comorbidities because of their social determinants of health, or they're impacted by their social determinants of health. Next slide. Another factor of risk adjustment of Z codes is payer ratings. So payers must be able to keep up their star ratings, right? So these are the elements that the payers are looking for from the provider community, okay? What are the outcomes? Is your patient population staying healthy? How are your chronic illnesses being cared for? Are you using chronic care management? Do you have a high patient population that is being readmitted into the hospital after 30 days after discharge? So if you look at some of the quote unquote stars that the provider community can manage and control, when we are poorly managing these aspects, guess what happens? The payers say, you know what, it's too risky to have you in my panel, and they drop us. So what we want to do is be great partners with our payers and provide this information so that they can keep the highest star ratings as possible. Next slide. Okay, so I've given you a lot of problems, I've given you some solutions, but what can we do, or what can providers do to demonstrate risk? First and foremost, never use an unspecified diagnosis code. There has to be some additional level of specificity there. I always believe it's there. But if that's not there, use signs and symptoms or document signs and symptoms. Validate illness severity and risk of mortality. So that kind of goes back into using those HCC codes and making sure that we're updating problem lists in the electronic health record. So what I see happen is sometimes old problems get pulled into new encounter notes, right? And if a provider is not treating an old diagnosis code, it should not be included in a new encounter. Follow medical decision-making guidelines. There have been some modifications after 2021's CPT coding updates. AMA has some really good resources for MDM for providers. MDM is not usually baked into electronic health records, so we need to use external resources to educate providers in that, and then obviously append those Z codes. Next slide. Okay, so how can technology, you guys who have been here, how can you help providers? So the first thing that I would recommend that you do, and Michelle talked about an example of a mechanic, you being in a mechanic's store or mechanic's garage, collaborate with healthcare providers and with their workforce, okay? Because the workforce understand what it takes to make all of this happen. The providers in the exam room or in an office, the other folks are, they're boots on the ground. So collaborate with them when you're programming technology that is going to be sold to them. And then incorporate reimbursement and regulatory guidance into the technology that you are offering and that you're implementing. When I come in and I do consulting with private practices on optimizing the use of the technology that they've purchased, most of the time they say, oh, this technology doesn't work, and I don't know why we bought it. It's not really about the technology not working. It's a lack of understanding of the features and tying that to the practice's workflows. So what we want to do is be able to customize that technology based on those revenue cycle components that I mentioned to you. And every single medical practice, although they're using those same components of revenue cycle, they have different approaches. So we want to make sure that we're kind of making sure that it's unique to the practice needs, to the provider needs. Every single provider practices medicine different. And I'm sure, Dr. Carter and Dr. Virgo can attest to that. I've been, a healthcare worker and working with 5 physicians at the same time. Every single one of them did their documentation differently. We had one person who was documenting while the patient's in the exam room, another one who waited, 48 hours to complete their documentation. So making sure that we're customizing it for the unique needs of the provider and their workforce. And then incorporate technology implementation within overall healthcare organizational needs. So reimbursement changes, regulatory changes, making sure that all of that is incorporated into the technology that you're offering. That is pretty much all that I have, and I wanted to leave some time. I don't have a watch on today, but I wanted to leave some time to open it up for Q&A. You can go to the next slide. This is just some, kind of conclusions, thoughts for you to think about, how you're going to implement social determinants of health and Z-code utilization in healthcare organizations. You touched on payment parity and with telehealth, and that is an area that we want to take into consideration because it is at risk. What we see is that the commercial payers especially, they are not seeing the level of medical necessity and complexity of telehealth visits as compared to in-office visits. And although we have that payment parity today, and CMS and others are reimbursing telehealth as if it were an in-office visit, that could change if we're not able to demonstrate that complexity of the telehealth visit. So that's something that we want to keep in mind. Next slide. So additional resources, thank you, Boyd, for mentioning the revenue cycle management book that we have here. I love everything revenue cycle. I don't know if that's come through me to you today, but I also have a podcast, Rev Dive, that's everywhere podcasts are available. I'm just got finished doing writing a second book with my co-author there, Taya Moheiser, who is the technology side of our duo. But I'm here to answer questions that you might have, to commiserate about challenges that you're facing. But again, thank you so much for having me.
And again, with this, all of the presentations that we have, we will put online for you. Thank you. Do you guys have any questions before lunch? I think everyone can probably smell the food. I don't even have to announce lunch. Everyone's going towards the smell.
Yes. Just one, oh, thank you. Just one, and my perspective comes from being a hospital board member. We hear a lot about claims denials and management of claims, management of denials, and I'm just curious whether in your book you go into a lot of detail about sort of how to manage that whole process.
There's a whole chapter on denials management, absolutely. So for me, denials management starts with prevention. So looking at the workflows that get you to the claim submission are keys to preventing denials. Obviously, denials are going to happen, but what we also want to do is we want to be proactive when the denial comes in. A lot of times what happens is staff have micro workflows that they decide which claims they're going to work, right? Which claims are going to stay on hold. So what we want to do is provide them with the motivation, the training, and the education to prioritize the right claims at the right times.
All right, I think it's a wrap. Thank you. So for the folks here in the main auditorium, we're wrapping up and letting you go to lunch. Thank you.